Well, hello, everyone. Welcome to our ongoing series of webinars for this COVID time period. Thanks for joining us. Glad you could be here for orthopedics and pelvic health from an external perspective. I'm Colleen Whiteford, physical therapist, and I'll be presenting tonight, or might not be tonight, but today for us now with this webinar. And I want to thank MyoPain Seminars for making this possible for us, and this wonderful series of webinars that we've had with so many incredible topics and presenters. So this is a list of the upcoming webinars that we still have. Obviously tonight's the June 16th one. Next week is whiplash and the 30th bruxism, and you can see the rest of the schedule. It looks fantastic. It's been fantastic. The topics have been great and really broad reaching, covering a whole range of perspectives from a lot of experts all over the world. So if you haven't caught any of these, you can get them from the MyoPain website, and they'll be available on there. You can watch them recorded, and hopefully you can join in live because we can take questions. And on that note, we have a questions box that we'd like you to use if you have questions during this time. And just write your questions in that box. Not a chat box, but it's a questions box. And I'll try to get to those during the webinar. But if I can't, I've got a couple places planned to stop, and then we can handle whatever else is left at the end. So we'll try to cover as many questions as possible and still respect everybody's time and get through the material that we want to. But I did want to say thank you to Jan and Mona for hosting this fantastic series, for the opportunity to be here with you guys, and thank you all for being here. We have a nice turnout of 200 some odd people from all over the world. So that's pretty impressive, and maybe it's because you don't have anything else to do, but nonetheless, welcome, glad to have you here. This whole series is being performed free of charge. We're doing it in lieu of registration fees, but asking that you would consider making a donation to the No Kid Hungry program. And you can go to MyoPain Seminars website and find there's a link to help you make a donation there, and that will be used to help kids. I don't know what it's like all over the world, but in the US, there's a lot of kids who count on school and the school day to get their meals. And right or wrong, whether we would agree with that or not, we want to be part of changing what we can change and helping these kids to get food, even though they're not in school. So if you would, we'd appreciate it. Instead of paying a registration fee for this webinar, if you would take a look at this and consider making a donation just to help these kids in moving things along. So as I mentioned, tell you a little bit more about myself. I'm a board certified specialist in orthopedic physical therapy, and that's a board certification in the United States. I have been certified in trigger point therapy with MyoPain Seminars, and that was quite a few years ago, 2009, I think. And I also am now certified with fascial manipulation through the Stecco method. I'm what's called a specialist. It's really a practitioner and an instructor in the method. I'm a member of the American Physical Therapy Association. I'm in the orthopedic section. I'm in the pelvic health section. I belong to the Fascia Research Society, and for the Fascial Manipulation Association, I'm a member also. And you can find me on Facebook. I'm on LinkedIn. I put my email address up there. That's cwhiteford@aptfc.com. That's my business. And I just started a blog, which never thought I'd do, but it's kind of interesting. COVID's given me a little bit of opportunity to expand out. And what I'm doing with that is sharing some of the conversations that I have when I'm in treatment rooms with people, talking about things that I think are relevant to a lot more than just the person that I'm talking to. A lot of people need better information. So it's my effort to try to get information out to people. So you're welcome to check that out at the addresses there at blogspot.com, I think. And you can, if you put your email in, then you can be notified when I post about every other week or so. So that's my hope anyway. And just to say a word about this title too, with the external perspective, I want to be really clear with just my thought process with that, in that I'm not saying that internal is out and that everybody should be doing external. I have training in internal pelvic, and I know some fantastic internal pelvic therapists who do amazing things to help people who have serious issues, and they are a lifesaver to those patients. So I don't want this to be interpreted that I'm saying it's all about external at all. I refer to these people often when I need help and I need someone else there who I consult. And I'm well aware of my need for having more external training too. But as I work in physical therapy for 36 years now, I've just grown to appreciate that there seems to be this gap between orthopedics or musculoskeletal, same thing, as well as pelvic health. And they just seem to be this big chasm that it's hard to cross. And the orthopedic physical therapists may not really have this sense of how close the structures that they work with or that they think they're targeting with the sacroiliac joint and the facet joints, the pelvis, how close it all really is to the internal organs. And also, I think it's possibly safe to say that perhaps the orthopedic therapists as well as pelvic therapists may not have ever considered the role that an old ankle sprain or something in the lower limb, that impact might have on not only the musculoskeletal problem, but also on the visceral problem, the internal organ problem. So my hope with all this is just that we might be open to looking at bridging some gaps and getting a better outcome for all of our patients. So just a little bit to show you what we do in our clinic with this slide. We have a really eclectic group of physical therapists. We have 3 clinics. We're in the United States, North Carolina, Virginia, and we utilize a variety of interventions such as you see here, dry needling, cupping, instrument-assisted, soft tissue mobilization. We have fit lights for external focus exercise, which Jan and Nate did a great webinar on a few weeks ago. We use a lot of fascial manipulation. We host courses in our clinic. We do a lot of mentoring. We do a lot of educating patients, like that's what the shoe is supposed to remind me of. I love the bottom picture with the little girl. I love working with the growing population of pediatrics because I believe that's where the life of prevention really comes in physical therapy. And also I have a growing population in women's health, which is partly what's prompted me to do this presentation. But our clinic also has a great group of people who like to have fun. And Jan and Nate talked about making exercise fun for the patient. And I think that's really an important thing for us to consider. But I think it's also important that we have fun as clinicians so that we can function at our best. So some of my pelvic training has come from these very good instructors. We heard from Jared Green a few weeks ago when he did the male pelvic seminar. I also had training with Dr. Joe Milius. And Dr. Ruth Jones are some of the folks that I've trained with. And as I've mentioned, I look forward to having more training on internal pelvic as well. But as I mentioned earlier, I'm a board certified specialist in orthopedic physical therapy. And I can tell you, I never set out with the intent of becoming involved with pelvic care the way that I have. But as I pursued my training in dry needling, it led to me being exposed to fascial manipulation. And as I worked with the fascial manipulation model, I became more aware of the global perspective of treating the whole body. And that got me into more with working with issues that I never thought I would have an impact on, like constipation and dysmenorrhea and pelvic pain, and making a change with these things when it really wasn't even my primary goal. And I found myself working the whole body. And ultimately, it also seemed to bring in the pelvic problems and that population that goes with that. So I highlighted some of what, and I probably left some things out of here, but if you look at all that's in that torso and just talking about, lumbopelvic segment, there's a lot of diagnoses that fall into that category. And I found myself working with those kind of through the back door, but ultimately getting good results with it. So I put this in here because I want to mention, if some of you missed the fascial manipulation webinar that we did back in April, I think it was great. It was me and my good friend and colleague, Larry Steinbeck, and we talked more in depth about the fascia manipulation method. So I'm not going to go into a lot of depth about that tonight because that's not really the role of this webinar. I'm kind of building from that and showing how we can apply that as well as some other interventions to treat a specific population and also show how it can be utilized from an external perspective. So when I mention pelvic and pelvic care and pelvic health, however you want to frame it, what's the first thing that comes to your mind? And please don't start writing your answers in the question box. It's a rhetorical question. But my guess would be that for many folks, that you think about the internal pelvic examination and technique. And the association of internal with pelvic is very strong in the United States. I'm not sure what it's like in other areas, but this is the hallmark of a pelvic therapist, for the most part, is that they are the only specialty that will do the internal pelvic for the physical therapy profession. So that association is pretty high. And there might be a couple thoughts or reasons for that. One is the pelvic therapists go through a lot of training. And this is just some of the courses that I listed out here that many of them move through at different levels. It's very extensive. There's quite a list. It's a big commitment to get into this whole body of coursework. And this coursework too includes pelvic, internal. So that's one part of it, and one reason why we may associate internal with pelvic so much. The other is that there's a specialty for it. Just like I have my orthopedic specialty, there's a women's health specialty. And it also reflects an understanding of the internal pelvic examination and treatment. Another element that may make people associate internal so much with pelvic is that there are a lot of tools that are used with pelvic care that might not be used in other modes of practice. And these things combined, I think, can pose an obstacle or make people sort of maybe draw a line in the sand when they're thinking about pelvic care, and just making them feel like it's a line that they're not going to cross. They consider that pelvic care is not in their scope of practice, and ultimately they just may say, well, yep, I'm not going to do that. That I don't want to do internal. And I was there, and before I understood more about this, I kind of drew that line myself. But the anatomy doesn't really support that kind of approach, and neither does our literature and research. So this was a study from Physical Therapy in 2017, and it just talked about the association between urinary incontinence and back problems. And they were basically reinforcing that they need to be screened in together. You can't just choose to look at one and ignore the fact that the other is present as well, because they're often together. This was another article from the same issue, which was all dedicated to the pelvic floor and pelvic problems. In this one, it was a case report where the physical therapist just considered impairments outside of the pelvic floor. She was looking more at the hip and pelvic segment from a musculoskeletal perspective. And she was able to achieve some nice improvements with the movement problems that brought the patient to the clinic, but also with POPs for pelvic organ prolapse, for urinary and colon symptoms, and the problems that all that can cause. So it was a nice case report on that. Another example of this sort of perspective in our literature, and this is from the Journal of Bodywork and Movement Therapies just last year. And they were working with patients who had chronic abdominal pain of unknown origin. They didn't have anything sinister, so it was sort of relegated to maybe the IBS categories. But they found that when they worked with dry needling to the abdominal musculature, that they had significant improvement not only in their chronic abdominal wall pain, but also in these other issues that you see listed there, which are often relegated to pelvic health, such as dysmenorrhea, urinary frequency, and constipation. So just another example of working outside, external from the pelvic floor, and still getting a nice response in that region. So this is a picture that might be familiar to many of us. It's from Travell and Simons, and looking at the referral patterns for the abdominal musculature. And you can see where there could be some interplay between the visceral internal organ complaints as well as external with the abdominal musculature. And looking at this next slide, I just wanted to point out how there's two different dissections going on here, really. One has got the fascia completely removed, but the one on the left done by the Steccos has left it intact. And you can get a nice idea, I think it shows, arrows coming in of the different directions of the fibers, which we'll talk a little bit more about later. But the point I want to make with this is that if you're going to needle the abdominal musculature, whether it was Travell and Simons in their studies, or whether it was the earlier study talking about the change with the abdominal wall complaints, you're still going to needle through the fascia. So you can't say it's completely isolated to just the musculature. And Shah and colleagues demonstrated that in this landmark study where they found these concentrations of biochemicals in the presence of the vicinity of a trigger point, But when I heard him at the Fascia Research Congress in Reston, Virginia back in 2015, I thought, how is he going to reconcile this? It's a fascia congress and he's the trigger point man. And he stood up and he just said, the science is the same because you can't study one without studying the other. They're so linked together. So I felt so much better after he said that because I wasn't sure how this was all going to work out in my paradigm, but that was good. And I just wanted to put a few of these slides in to that point, showing how intimate and relational the fascia and the muscles are, that it's in some places you can hardly separate them without damaging one or the other or both because they go together. So the studies really do reflect the science that's behind both. And this is just showing muscle inserting into fascia and the way they meld into each other. You can hardly tell where one ends and one's beginning except for the color of it. So there's a lot of research and growing body of research and great minds that have contributed to our understanding of the fascia. And it's just been really neat for me to see in my career how much more it's being looked at. It's so many great minds and so much more that we understand about it, because when I was in school, I learned next to nothing about it. One of the great contributors to our understanding of fascia is Dr. Carla Stecco, who's a physician perhaps many of you are familiar with out of Italy. She's an orthopedic surgeon who does a lot with research and anatomy. She wrote this wonderful resource that I enjoy and recommend on the Functional Atlas of the Human Fascial System. And she's done much to help our understanding of the fascia and what its properties are and its behavior. And she recently was part of one of many webinars that we're all enjoying now because of COVID. But her topic in this particular one was on the pelvic floor fascia. And I really enjoyed hearing her perspective on it. But in the slide, you can see she's talking about how much interest there is, how complicated it is, but the representation of it contributes to how complex it is, and it avoids us being able to understand how continuous it is. And some of her comments were that it was very complex due to multiple layers as well as multiple names. And there's all these different names for the structures: fascia for the bladder, another one for the uterus, another for the levator ani, another for the rectum. And it makes it almost impossible to understand how the continuity of the whole region, that it really isn't all these separate structures. She went on to say that people tend to focus on the part they deal with and they overlook the others, and yet it's continuous. She went on with further beautiful slides showing her work through the University of Padua, where she is in Italy, and showing just scarpus fascia, the superficial fascia of the lower pelvic region, and Colles fascia, which is the superficial fascia of the pelvic floor, the continuity and how they carry into the lower limb, but just that it's not this divisive area with lots of different dividing lines, but it's very actually continuous. And she, in the posterior aspect, she made the comment that the external anal sphincter is connected to the coccyx by a fascial bundle. And she was lifting on that and highlighting that here. So further slides that she shared that were really neat. Now she was moving into the deep fascia and just showing the relationship of the external oblique and how it crosses over at the symphysis pubis. And her comments with that. This shows the crossing in the midline of the external oblique fascia at the symphysis pubis, and it moves toward the contralateral lower limb, and it stretches this at the unilateral and the contralateral, mostly toward the medial region of the adductors. And again, that continuity just coming into play. The fascia is also in continuity with the fascia of the pelvic floor. So great comments and illustrations based on anatomy and not just speculation. And here we are back with a figure from Travell for the adductors and showing maybe this is what Janet Travell was experiencing and finding with her studies and her work, was this relationship that Carla Stecco was showing out with the cadavers between the adductors and the pelvic floor musculature, and maybe can explain some of this relationship with pain and other dysfunctions from one region into the other. So this was a lovely lady who made me look really small. She was from South Africa, and she came all the way from South Africa just to see me. Not, but I had the privilege of working with her after her first child, and she sustained, unfortunately, a 4th degree perineal tear, which is a nightmare. After that, she had basically what's called an OASIS. It's a obstetrical anal sphincter injury, and it left her with urinary and fecal incontinence. And at a young age, after your first baby, that's not a nice place to be. Baby was 9.5 pounds. She was late, and just a lot of issues to deal with. So she came to me, and she was trying to avoid surgery. Her the surgeon she saw, I believe it was over at UVA, had wanted her to try physical therapy first, and I thought that was wonderful of her. And so we worked with her. I saw her for 6 visits, and you're going to see a little bit of what we moved through in a similar, different case, but similar, just with working with her, the fascia manipulation, a little bit of exercise, and she's doing very well. I saw her for 6 visits. It was all external. There was no internal pelvic work done with her. If I needed it, if she needed it, I would have been happy to refer her or do it myself if I felt comfortable with it. But as it was, we were able to take care of her issues, and in follow-up by phone, she's still doing very well. I'd like to see her down the road again and just make sure we've cleared up everything. But for the most part, that was just a nice result and a good example of what I'm talking about. So there's a lot in the literature that's supporting this anatomical relationship, and this was a nice article. Back to the Bodywork or Journal of Bodywork and Movement Therapies. This is from Antonio Stecco and his group, and they were showing the relationship of the fascia lata to the gluteus maximus. So showing how the posterior hip, it relates to all the fascia of the thigh, and that it transmits forces all the way down to the knee. So just concluding this webinar that Carla Stecco and so many other great minds were part of, she had these comments: the anatomical continuity between the pelvic fascia, the fascia of the abdomen, of the back, and the thigh, and that a problem in the pelvic floor can be caused by an alteration of all these areas. That this continuity between the visceral fascia and the locomotor system means that if you have a problem in one, it can impact the other. So sometimes we get hung up on, is this a viscerosomatic problem? Is it a somatoviscero? Is it viscero-viscero, somato-somato? I kind of say, well, anything's possible and it's believable, no matter which way you want to draw the lines, because they're so interconnected with each other. And maybe that's kind of what I was hitting on when I had the opportunity to work with this lady. And I had the privilege of writing a chapter in this book by Julianne Day on the fascia manipulation method. Each chapter was like a case report done by clinicians from all over the world. Larry Steinbeck has a chapter in it, and probably, maybe some people, Cheryl McGallis might be listening here, and lots of others who are fascial manipulation instructors and practitioners. And my chapter was on resolving urinary incontinence in a runner postpartum. I never would have imagined that I would be writing such a chapter, much less on urinary incontinence, because of my strong orthopedic background. But it was a great illustration of how working with her externally, it worked for her to stay external, but also that one of the areas I worked on with her, if you can look at some of those visits that I laid out there, I saw her for 5 visits. 2 of them were purely for a running analysis, so I didn't even work with her. So essentially I saw her for 5 visits and then 2 for the running. And she did very well in that time frame. But part of her treatment was going down to her ankle, because she had an old ankle sprain, and that seemed to play a pretty significant part in getting her better, and was just part of her history. And I'll talk more about that as we go along. I'll show you some of the cases of how that really comes into play. So in my practice, our practice, we see pretty much the same things as most any other outpatient musculoskeletal orthopedic practice, with necks and backs and shoulders, temporomandibular, knee, wrist, you name it. Post-op, I don't do quite as much with post-op anymore, but we still see that. And, like any other practice too, part of what we would always include was a medical screening form. And I would note that when I was starting a new patient, I would see whatever they filled in, whatever their problems were. But as long as they were under control, there was nothing, no red flags, nothing serious that I felt like I had to step into. As long as something else was being managed by someone else, or they were taking a drug for it, I felt like it really wasn't my scope of practice. But the more I learned and the more I studied with the fascia manipulation method, the more I became aware of this relationship between the locomotor, or the somatic, the musculoskeletal, and the internal organs. And as I brought that more into my practice, it changed my perspective, but it also really changed my practice. And this was when I was in Italy and I got certified. And that's my picture with Luigi Stecco there. And I call that my $10,000 t-shirt. So it's a nice one. But my practice really modified in that now instead of just seeing people write these things on their intake sheet, I was actually processing how did that come into play. Maybe that was part of their knee pain. Maybe their knee pain was driving some of their visceral problems. But I would actually begin to get patients who were coming to me primarily for their visceral dysfunction, such as dysmenorrhea, sexual dysfunction, organ prolapse, urinary incontinence. And there's a big misunderstanding about urinary incontinence. It happens in a lot of athletes, runners, and also in youngsters. It's not just an old lady's problem or an old man's problem. But I have worked with some men with pelvic care. It's not the stronger part of my practice, but working with fascia and the interventions that I do has enabled me to branch into that as well. Diastasis rectus, irritable bowel, all kinds of things that I never would have thought that I would be working with. So this next slide was to remind me to maybe pause for questions and to give you a laugh. And I'm trying to look at questions here. I might lose this slide for 1 second while I slide my bar over. I'm not the best with, oh dear. I think I'll go back to my presentation. I'll get questions at the end. Sorry, I'm not switching between the places very well. So we'll come back to it. But anyway, I got this from my friend Kinter, who's Scottish and loves beer and lots of different kinds of drinks. So I thought it was good for a laugh. So anyway, let's look at, so I like this slide because I think it sort of shows the process that maybe we all move through. That's like a funnel. And we start with this, maybe this history with this person who's got stuff everywhere. How do we funnel it down? How do we make it manageable? And how does the pelvis fit in with all of this? So I want to walk you through a little bit of how I manage that. So this is just one of the intake sheets. It's already been changed even since I made this slide. But I like to know everything about a person. I like to know the musculoskeletal, and I like to know the internal stuff. So they may come and only fill in a few things, and then they tend to leave alone the things that they don't think are important, or they say, that's not why I came here. But I like to know about everything, and even back to childhood. You know, were there traumas or anything? And on that note, the trauma is important to note, because it may give us a clue of where a problem began, why a problem began, but it makes a difference in how I approach someone. And, you know, some of the pictures on the right are obvious traumas. Surgery is considered a trauma because the tissue integrity is violated, grows back together, but it changes things and scars. I consider pregnancy a trauma. Some, like the girl I was showing earlier from South Africa, more of a trauma than others. Sometimes trauma for the mom, sometimes trauma for the baby in quiet ways that we may not even pick up on as a huge problem, but subtle stuff. When people can't think of any reason why they have a problem, what they could relate it to, sometimes I like to point out that, you know, we start falling down from the moment we start standing up. And maybe that's where some of our traumas come from. When I see a patient, I like to look at them, and I like to see skin, and I like to see structure, because structure tells you a lot about function, and it tells you a lot about dysfunction. So I'm looking at, like the gentleman in the left-hand corner, the tibial torsion that he has there, especially hard on that left leg. I'm thinking, he's got something pulling him over there. Maybe it's his foot mechanics, but maybe it's something on the lateral aspect of his leg, some fascia pulling there. The knee, the foot here, the point called retropes in this foot is big compared to the other foot. That gives me a clue of maybe I want to check out that spot and see, okay, do we have fascial dysfunction here that's enlarging that? Excessive lumbar lordosis, maybe we've got some overactive lumbar paraspinals, underactive abdominal obliques. Toenail health I like to see, because it tells me maybe the fascia that the nail is embedded in is dysfunctional and needs some attention. Of course, leg length discrepancy, scoliosis I want to see. Skin can tell you a lot of information, can be a roadmap for where there's dysfunction in the body, if you know how to interpret that map, if you know where the map takes you. I put this in just showing the distortions in this gentleman's body just from standing at his head and looking down at the shoulder on the right being forward and the lower extremity on the left being externally rotated. So they may be giving all kinds of clues as to where we need to be working. So my next element is movement. And this is first day, but I always revisit these things. I want to narrow down. I want to start this funnel process moving from their wide array of complaints. I might be moving the area that they're complaining of. And my movement is nothing special. We all do this all the time. I utilize triplanar movement, frontal, sagittal, transverse, and I may do even some diagonals and crossing plane, depending on if I'm trying to find a movement that is a problem for a person. Or you can use a gesture, like when they reach into the back seat of the car to get something. That's the gesture that would be a problem for them. When I'm talking about a pelvic patient, though, the pelvis isn't the greatest segment to move. So I tend to move the lumbar segment, and I do it in standing, and I use triplanar movement. Or if they have a gesture, like they want to imitate something, but I'm looking for hypermobility, hypomobility, or pain, restriction, or asymmetry, especially with side bending. Can they side bend to one side better than they can the other? I like moving the hips as well because they're on the other side of the pelvis, and they might give us more information about a problem, but also let us know if we're making a change for someone. Triplanar movement. And I also like using a squat if a person is capable of doing this safely and without aggravating their condition, so that it just gives a global assessment of the lower half of the body. And it's a quick and easy way to look at things. I also like looking at the hips on the table, whether it's seated or supine. I like getting a feel what's happening passively in all different directions, and just movement in all directions. What will the hip and the pelvis and the trunk allow to happen? And I even look at the shoulder to see, does that tell me anything about the rest of the trunk? Because it can give you some interesting information. So our next element is palpation. And I'm narrowing my funnel down. I'm not going to palpate everywhere, but I'm going to pick a few key places that tie into the person's complaint and tie into their history. And so that, usually for the pelvic patient, it's going to take me to the segment of the pelvis, or all of these are abbreviated in Latin, pelvi. So it would be not just the bones of the pelvis. I'm not just looking at, does this person have an upslip, a downslip, an inflare, an outflare? I've spent so much time palpating those kinds of things on people and treating them over the years too. It's been my experience that I get a better response from a person if I pay more attention to the connective tissue and not focus so hard on what's the bony alignment of the pelvis or any other body part. But it might give a clue, but I want to know more than just the ASIS height, PSIS. I want to know about all those connective tissues. I'm palpating lymphatics, blood vessels, nerve vessels, superficial fascia, deep fascia. And then I'll usually pick a second segment somewhere in the lower half of the body, maybe that has some history that goes along with it. So I like to show this picture because I think it helps people understand what I'm talking about when I'm working with them about fascia. So I say, fascia is that white filmy stuff. This wraps around meat and it wraps around everything in your body. And it's continuous from head to toe, right to left, front to back. This is my husband cleaning a deer tenderloin in the kitchen. It is not a cadaver, but it is an unembalmed sample. So it's pretty neat, close as we're going to get for a while. And what he's lifting up on is the superficial layer. But what you can see, that thicker, white, milky looking layer behind is the deep fascia. And it looks like one thick layer, but you can also almost get a sense that there's multiple layers to it. And that's because there are. And we can see that's a little bit different in this schematic. So this is just showing that layered formation. He was lifting up on that superficial fascia right along in there. And that thicker part was this down here. And it's not just one thick layer that's laying on top of muscle, but it has a very different formation. So this is just showing this is from the elbow, and it's showing the actual different layers and how they crisscross each other because they're laid down at different angles to each other. So we have collagen fiber bundles that are laid down parallel to each other by layer, but the layers are oriented at different angles to each other. And this has been shown in the literature. This paper, they talked about the lattice-like arrangement and they were looking at the ankle retinaculum and also talking about how it wasn't those easily identifiable Y bands and the different way that we are used to seeing it in our anatomy text, but it was like one stocking that just got thicker at those points. I like using this picture because I think it helps people process what I'm saying about that deep fascia, that it's multiple layers of collagen fiber bundles laid down parallel to each other at different angles according to the layer. So one layer may be oriented this way, another layer that way, hence the lattice-like appearance, and it's thought to rule movement according to the direction of the collagen fibers. And the layers have to have space and they have to have slide, and that's a key thing. And that's what this study was showing, that you can get into problems with the layers. A is what we want. They're on the left-hand side, but B is what happens when the fascia becomes dysfunctional. So A, we've got space and we've got slide between the layers. The depiction on the B part is where there's what's called the densification, where we've compromised the space and we've compromised the slide. And everybody wants to know, how does that happen? And I like this slide because it just is a very graphic demonstration of overload. That's my elevator answer to people. Overload is thought to be what gets the tissue layers into trouble and creates densification. And overload can happen with injury or trauma, repetitive movements, or immobilization. And what's happening in there is just our normal lubricant, our biomechanical lubricant of hyaluronan just it increases in viscosity. It becomes thicker and it's not doing its job anymore. Instead of lubricating, it becomes adherent and it changes the ability of those tissues to move. So this is one of the fascia manipulation illustrations of some of these points throughout the body. And I like showing this to people because it can say, well, if a densification happens in a region over here, if the tissue layers get stuck over in an area where there aren't some of these points, these dots, it's not going to have as much of an impact as it will as if it happens in one of these points. And the blue point for the lateral pelvic relates to lateral lumbi through the fascia. The muscle fiber bundles for movement in a lateral direction at the lumbar segment relate to the pelvic segment. We went into this more with the fascia manipulation webinar, so I'm only going to touch on it. I'm sure those of you who haven't seen that webinar, you're probably not going to get all your questions answered about this, but I'm just touching on it and encourage you to go back and watch that webinar. But one thing I like to point out too is the continuity. So intrascap relates to intrathorax, relates to intralumbi, and if we had it in the picture, intrapelvi, all the way down the line, and the dots are the same color because they relate to each other for movement in a specific plane of motion. And this has been shown in the research, where there's lots of this research now, as well as these literature articles are looking at this force transmission, that the transmission of force can happen between adjacent structures, adjacent segments, and it's a very interesting phenomenon that we're really just coming to appreciate. This was showing, I thought this was rather relevant for this, in vivo, meaning this is a live subject, where they were monitoring movement at the pelvis and at the gastrocnemius. And they were doing it with a ultrasound and then a two-dimensional kinematic analysis, and finding that when one would move, the other would move, that there was force transmission shared between the pelvis and the calf. And so that's one reason why we'll look at the calf and the segment of talus, perhaps, when we're looking in the fascia manipulation model for that other segment down into the lower limb. There's this relationship. We talk so much about the biomechanical chain and the kinetic chain, but I like this method, the way that it really brings it to play, and what does that really look like in practice? I tell people, to me, I'm connecting the dots. I'm just connecting the dots from head to toe, right to left, front to back. What's the relationship in the pelvis to the lower extremity? And I'm trying to find a predominant dysfunctional tissue line that, if I address that first, might get the best benefit for the patient the quickest. So this was a nice paper done by the research group in Italy, and they showed a relationship between the external oblique and the thoracolumbar fascia. And so showing this whole container, how it relates from front to back, and the relationship and the ability of the fascia to transmit force by virtue of just the anatomy and the relationship between the two. So I use this very primitive diagram to just talk about internal organs. And a lot of these are what I share with patients, which I'll touch on in a little bit. But I like to point out to people that, your organs are typically pretty uniform in all of us, basically in the same places, relatively speaking, and they're organized and they're held in place so that when you turn on your side, things don't jumble around. They can't, or you would get in trouble and your internal organ function would be severely compromised and your life might be as well. And what holds it in place is the fascia. And the fascia not only wraps around and invests into these organs, but it then attaches itself at certain points to the trunk wall, which makes perfect sense to hold things in place and keep things organized and where they're supposed to be. I liken it to a tent. And I like explaining to patients this way, that if you think about your trunk, your torso is like the canopy of the tent. And then your arms and your legs and your neck are like the ropes. And your head and your hands and your feet are like the stakes that drive it in the ground. And it's all counting on the other areas having the right amount of pull, the right amount of tension in order for the structure to function properly. In this webinar that I was referring to earlier, Carlos Stecco used this illustration and comparison to more of a bridge, and that you have to have these distal tensors pulling to keep the pylons upright for the road deck, which could be equated to our trunk. And just superimposing the body on that bridge model, this is what it can look like. And I think it helps me and others understand the relationship between the limbs and the trunk and how important it all is for proper tension throughout all these structures. This was a lovely article by Dr. Vanderwall, and talking about this concept in terms of the trunk cavity, that there has to be this relationship, and he's using architectural models to write about this, that there has to be this relationship to preserve space so that the organs have the space that they need, but also that they connect in a mechanical manner to the limbs. So this is in the Journal of Bodywork and Movement Therapies as well. But just a great illustration in bringing the science into it. So with my palpation, I'm either working with my elbow or my knuckle. And I've learned to feel with my elbow. I'm not just treating with it. I can treat with either, but I'm still talking about basically when I'm assessing these tissues. And I'm feeling for that densified tissue. Again, I'm not going to get into this because we went more over it in the fascia manipulation webinar. But we're feeling for that point, like I showed you on those pictures earlier, where the tissue feels thicker, where it feels rigid, where it doesn't slide and give the way that it does in other areas. And usually it's a painful place too, but that's not always the case. All right, so I'm finishing the palpation segment. Now I'm into talking about my approach with people. What do I do then in treatment? And now I've narrowed things down. How do I move into treatment with these people? And I like to think about my approach to treatment as being like 3 parts. And basically, I think one of the most important things that I have to offer a patient is educating them. And I spend a lot of time educating people, and I charge for it too. There's a CPT code for that, and I think it's perfectly legitimate. I think it's one of the most valuable things we can give our patients because we can equip them and enable them to help and participate in their management. So I teach them about fascia, and I show them a lot of the slides I just shared with you. I talk to them about activities that they're doing day and night that might be playing into their problem. And this is really true for whether somebody's coming to me for a pelvic problem or any problem. We work a lot with breathing, and I'll show you a couple of the tools that we use for approaching breathing, but people oftentimes don't even realize that their breathing is so dysfunctional and so abnormal, and it can really be disruptive to your body. We all are used to talking about posture, but teaching people more about what that really means, what good is, what bad is. We talk a lot about footwear for people. I like to teach a lot about hypermobility because I find I just see a lot of my population has hypermobility to any degree, from Ehlers-Danlos to just mild hypermobility like I myself have. And we use a lot of brochures and videos, which I want to share with you here. So I named this GEMS. I'm not going to go through this whole thing. This is just my I have a PowerPoint on my computer that I keep up and loaded, and it's just a mishmash of a bunch of slides that I often want to have so I can help a patient understand what it is that's wrong with them and how they need to understand that to change the problem. And a lot of what I've shown you here is what I have in my gems. And I don't show them a whole slideshow. I just pick out whatever I think is going to be most helpful for them to understand why I'm saying they need to do what they do. It helps them buy in. I also use brochures. And these are brochures that I've made a lot of them. We've all participated in them in our practice, but I really couldn't find good brochures available through some of the companies you can order them through. Some of the topics I picked just to, and these are not all our brochures. I couldn't even fit them all on here. But we talk about, these are the topics I thought were relevant to this talk tonight. I just did the one on dysmenorrhea because I really believe that a lot of the women's problems that I see later with pelvic stuff, most of them have a history of reporting problems ever since they started their cycle. And I would really love to get to those women, girls, earlier. And I think an ounce of prevention is worth a pound of cure, as they say. But I like giving people something they can walk out with, go home, read it. This is part of your homework. But I also use it as a marketing tool. They talk to me about a friend or a family member, and I can give them a brochure and say, take this to that person. Or I give it to the mom so they can read more about the problem that their child or their husband has. I like using this slide a lot. I just think it boils it down. To me, this is kind of my biopsychosocial summary that I point out to people, you know, you're not responsible for some of these things if they are relevant to you. You can't help what happens to you sometimes, but you can help some of this. And everybody's got different emphasis. For some people, their daily activities are a huge part of the problem. For other people, it's got more to do with a trauma. Everybody's different in the mix, and even every day somebody might be changing the emphasis of one or the other of these influences. You know, we're trying to change maybe movement patterns, trying to change daily activities for people. Can't do much about what's happened, but we can try to impact a movement pattern that maybe has changed because of that trauma. Can't really change the genetics, but if you even just understand how it plays in, it can help you with management. But I tell people I like to change whatever we can change, and then maybe what you can't change won't be such a negative impact for you. So that's my education part. So next, in treatment, which I consider like and this is not necessarily in the order that I do things. It's just an organizational order to present it. I use fascia manipulation, dry needling. I use mobilization, stretching. But fascia manipulation and dry needling are probably what I use more than anything else. I do use exercise, but I'm going to consider that and talk to that a little bit more in the next part of my third element. I like using these interventions a lot. I think they're fantastic together, and they play off each other nicely. And I learned long ago, you don't have to decide, are you going to be in the fascia manipulation camp? Are you going to be in the dry needling camp? I think they work really nicely together. And knowing fascia manipulation has made me a better dry needler in my experience because it helps me be more precise in where I want to needle and narrow it down and maybe look broader beyond just the area that the person's complaining about, their site of pain. So my third leg in this whole triad for what I use in treatment is just what I call equipping patients. And I use home exercises, but we had that awesome external focus or playground one that Jan and Nate did a few weeks ago, which was really good for me to watch and see and think about. And I try to bring in stuff that's fun for people, but I also think there's some things that they need to do at home. So I put max 3 there because I do not give a patient any more than 3 exercises. I think they won't do them. So I limit it to 3, but I also tend to change the exercise every week so that there's advancement, there's change, and they don't get bored with it. And it's reflective of their change in status. So it's pretty particular to where they are at that point in time. We do a lot of work with breathing retraining, which I'll show you a couple resources for, and a lot of other homework, as you can see there. I have people using percussion and vibration therapy balls And I'm realizing the time, so I need to hurry up. So I'm going to speed up here. So I put this in for questions. It's a cute little slide, again, for my friend Kinter. And it took me a minute to get it, but I thought it was cute. So I'm not going to stop for questions here because I want to try to get through at least one of my case reports. And if I can't finish the other, then that's okay. So we'll come back to questions. So I want to show you one case, and this is a story. I don't consider it a report really, but talking about a diastasis. And this diastasis, there's a lot of experts out there. People, it's gaining a lot of popularity, it seems, where people position themselves as being the expert on it. And there's a lot of different opinions on how to approach it. Really, the literature shows that it's really not well understood. There's a lot, this paper spoke to that. There's very little scientific knowledge that elucidates what's really going on with it. There's a lot of opinions, but that you need to be careful approaching it. This was a nice paper by Diane Lee and Paul Hodges. This was in the Journal of Orthopedic and Sports Physical Therapy, where they basically gave support to what had been discouraged with doing a pre-contraction with the transversus abdominis before doing other exercises, just to minimize the impact on a diastasis rectus. So nice article that's kind of changed how we might have thought about it. Although now what I see a lot of people doing is talking entirely about recruiting the transversus abdominis to heal the diastasis rectus, and I'm not really sure that that was the intent of this paper. And my experience, I use a couple other interventions besides that. This was, if I have this right, if I'm remembering right, Dr. Van Wingerden just recently did a fantastic webinar for the Fascia Research Society on talking about his work and this paper, where he found that they were looking at diastasis rectus and just the relationship of the transverse abdominis to the rectus abdominis. And what they found was really there was a stronger relationship between the posterior fascia, the fascia on the posterior aspect of the rectus abdominis, to the transverse abdominis than there was between the two muscles, the rectus abdominis and the transverse abdominis. The fascia had more of an impact and relationship to the transversus abdominis. So if we're going to talk about and emphasize transversus abdominis, you got to consider the relationship that that muscle has with the fascia in the torso. And he was also talking about the stiffness of it and how the stiffness in certain directions can be a problem. And I think that that may give some explanation and support to what I did with this gal then, who came to me for diastasis, but she also had urinary incontinence, 29-year-old, second child, I think it was 5 months postpartum, and really concerned just with what was going on with her body because she wants to have a third child. It's good to think about before you load the body again. So what I worked on her here was fascial manipulation on points that I found densified in the torso, and I put them up there. It's the yellow triangles, antilateral pelvi, and I'm doing manual techniques on her. But what I also used was it's called the Viper from Hyperice. Nice piece of equipment that helps to prep tissue, so I think it's a little less painful for people to work on manually. And I'm actually using it on the opposite side just to try to distract her while I worked on her very densified and very uncomfortable left side. So just showing some aspects of treatment, using the Hypervolt then down at her ankle for the same tissue line in antilateral talus. So this is the other tool that I use. And there's a lot of opinions about pelvic tilt. I like using it on someone like her. I'm not going to give her very hard, high-level exercises to be working on when she's still so acute with her diastasis, but we're going to start some work and do some gentle stuff. I use posterior pelvic tilt in lots of positions. Supine, all fours. I do it in seated position. You can do it on the therapy ball. You can be creative and just do whatever works best for that person. I threw this in because I just wanted to comment about Kegels. I think this was interesting from the section on women's health that this was a quote. And it's true, a lot of the women, they're reading on the internet and they're being told by their physician that, well, just do Kegels, that's all that you can do. And that's kind of akin, as far as I'm concerned, to someone coming to me for knee pain, any knee pain, and me just saying, well, just do quad sets. Do quad sets all day long, forever. And it's pretty frustrating to women. Kegels may have some value and some benefit in some cases, but to expect them to do the whole job is pretty insufficient. We have a lot better, more tools to offer than that. So a little bit on the breathing piece. I used this with the other girl because she had dysfunctional breathing. A lot of women do after pregnancy. That's understandable. And these are just a couple of resources where you can see, they're talking about breathing. I like using balloons if somebody's really having a hard time with breathing. It helps them move along and maybe recruit abs a little bit differently. I put this in just to show you a couple of resources. I'll use the book if I've got someone who I think really needs to work on breathing exercises. And then there's a DVD set walking you through a Buteyko training seminar if I think somebody needs to be in a class because they're so bad and they're going to need to have it reinforced by an instructor. So just a couple of tools that I like to use. This is one of my favorites, and this is my diastasis girl. Look at how much fun we're having. I love hula hoops, and what a great core stability exercise. And I love my job, and I get to work out with my patients, have a good time, and I can hula hoop. I can do it. I do better when I have my right leg forward, so I'm working on left leg forward, but I really like hula hoops, cheap, external focus. The moms can do it with their kids, so lovely little tool to have on hand. This is a little, I just threw this in as one option for assessing core stability. There's a lot of, opinions about what is the core, how do you assess it, but I think that some of the planking maneuvers they offer here can be helpful in just letting a person know where are they in their progress and maybe helping you with guiding some of the exercises you choose. All right, I'm going to run through this story really fast. One other case report. She came to me for, what was it? Okay, in idiopathic patellar dislocation, 15 years old, no idea, no trauma, no nothing, walking and it dislocated. And I'm just going to scoot through these. And they said she had a medial-patellar femoral ligament tear, but she never had an MRI. Anyway, we had the usual strengthen her leg, quad sets, do all that. But they really didn't know why it was happening. So we did the usual stuff. She was doing great. She was hypermobile. She was pretty hypermobile, which could be a factor in that dislocation. We helped with bracing. She was moving along beautifully toward her goals. And, I'm feeling, yes, proud of myself. She's doing great. But this one stopped me. And she said this to me one day in the parallel bars while she was doing her leg stuff. And I thought, you know what? She's right. How do we know it won't happen to her again if we don't know why it happened in the first place? And so we need to figure out why. Nobody else is going to figure out why. In the whole medical chain, the buck stops with the musculoskeletal, the therapist, neuromuscular, physical therapist, whoever you are, whatever your perspective. Because of this word, idiopathic. Adam likes to say in my practice, it just means the idiots can't figure out the pathology. Well, we have to figure it out. So look at her legs here. Can you see anything? Don't type that in that question box. It's a rhetorical question. So I drew these lines. There's a little bit of a difference in the angle, isn't there, on the left knee? That happens to be the one she dislocated. Explanations. I think she's got something pulling her there. So I palpated. Because once she was finally less acute, I could palpate her. And this is what I found. Antilateral genu, retrolateral genu. And I also recall, though, that she had an old ankle sprain that she told me about on the other side, the right ankle. And so we included that in our palpation, and we found correlation. Both ankles had densifications. And I'm drawing my line. But here was an interesting little caveat that she initially didn't tell me about. She's 15 years old, and she had such dysfunctional menstrual cycles that at age 13, she had an IUD inserted. That's pretty extreme. So now I'm thinking, okay, now I've got orthopedics, I've got pediatrics, I've got pelvic. So this is what I thought might be a plausible explanation for what happened to her. She sprained her ankle first. Then the next thing in the timeline was she had that IUD put in. She started her cycles, and within a few years, then she had this dislocation. I'm not saying the dislocation happened because of the IUD. I'm saying it happened because none of the problems were being addressed adequately from a musculoskeletal perspective. Each problem was being isolated by itself and not looking at the whole in this girl. So we went to work, and you might have seen this picture on the MyoPain website, and she was a sweetie. But here I am working on antilateral pelvis, and I'm going to go fast. I did her ankle, and I like the kids especially. They like helping. And so I would let her use the hypervol on one side. I'm working the other side. I can get more done. I can get caught up when I get behind. So this was her last visit with me. And this was before treatment, because I know she's wearing cutoffs, and I don't work on people in cutoffs. I make them change into stretchy shorts. And she's squatting, and she's very proud of it. But then we did one more treatment that day, and I can't remember what it was. It doesn't matter. But I did a little more fascial manipulation with her, and I brought her out again to squat. And this is what she did. She almost fell over because she gained that much more range just from that last treatment. And she's doing very well. And my hope is that when, you know, she wants to have kids in life and has that IUD removed, hopefully some of what we did may make it all go better for her. Either that, or I put a bug in the parent's ear. Maybe she's going to need to come back, you know, and have a little more treatment for that other problem. But I just like this whole thing because it sort of shows the relationship. So Shirley Sarman, wrapping it up here, we're responsible for all these. And she highlights, you know, neurological, integumentary, respiratory, but I would also throw in, you know, digestive, urinary, reproductive, all those could be up there. The interaction of all these systems working together. So what's your line in the sand look like? I like this one. And I think we have the freedom to get creative with it. You don't have to be so rigid with your line in the sand. Just think outside the box a little bit, and maybe you can have some fun in your clinic. So that's the end of what I had prepared. And now we can try to go to some questions.
How is Stecco's work different from many other fascial types of therapy that are already out there?
Yeah, well, I think it's safe to say there's probably some similarities and some overlap there is with a lot of these systems. And I'm not trained in all of them, so I can't speak specifically to the others. I only know what the FM, fascial manipulation system, has is a method for approaching an organized way, like moving from that funnel, from starting with the history and narrowing it down with movement, palpation, finally treatment. The other systems may do that too, and I'm not as familiar with as many of the others. I just happen to be more trained and well-versed in the FM method, but I know there's some similarities. I hear people who like they talk about they work a lot with anatomy trains and that sort of mindset, but that this goes a little bit more specific, a little more deeper into more of the science behind the fascia. But there's probably a lot of similarity. I know too, like a lot of people, for instance, doing fascia work, maybe like using a foam roller or some of those other tools, even the instrument-assisted devices, they're probably targeting the superficial fascia more than the deep. Just because you press hard doesn't mean you're necessarily getting to the target tissue. So it's different ways of looking at it, but this method to me makes sense based on a lot of the science that's out there. But the others, there may be a lot of similarities. I don't know about all of them, but I think there's value in a lot of different techniques and different approaches. I use some other things because I don't always use the FM approach. I bring back some of my older stuff that I've found to work well for different people if they can't tolerate the FM approach. So it's good to have, you know, different tools in your tool bag, and there's probably a lot of similarity. I just think there's a lot of value in this because of the way it moves you through in an organized manner and brings you to a conclusion.
Here's a question from Vladimir, I believe from Latvia, if I remember correctly. Yeah, Dr. Whiteford, in which cases is it more valuable to perform superficial dry needling alone compared to deep dry needling in the pelvic floor area?
Well, that might be a question Blair Green can answer better than me. She did the webinar last week on dry needling to the pelvic floor. I wouldn't even begin to know how to answer that one. I would say it's a matter of your perspective. If you can't do needling, then you're not going to do either, obviously. But remember the slides I showed from the Stecco webinar, where Dr. Stecco was talking about the pelvic floor fascia, how intimate and connected it is to the other tissues of the abdomen, the back, the hip, the leg. So to me, you don't necessarily have to go to the pelvic floor. Maybe if you're a needler, you could do superficial or deep dry needling in any of those structures, even if you're not trained and don't feel comfortable in the pelvic floor. But you could also do manual and do non-needling interventions as well. But it's probably a question better directed to Blair Green, her email's on the webinar, and might be good for her to answer.
Here's a question from Dr. Mohammed Asif. Hello, Dr. Asif. It's very late for you, if I'm not mistaken. This is from Karachi, Pakistan. Dr. Asif and I know each other. He has a question. The entire webinar you were discussing only women pelvic problems. Why did you not include any men's pelvic floor problems? Can you please speak a few words regarding men's pelvic floor issues and your approach?
Yeah, I was specifically trying to not be too specific to women, so sorry if it came across that way. My practice, as I mentioned earlier, I started out as orthopedics, and then I kind of got into the women's pelvic stuff through the back door, almost by accident. And so I haven't promoted it a whole lot, and it seems to be growing on its own anyway. I'm kind of taking that same approach with the men because I see men, more women for sure, but I see men, and I don't want to go like market or put myself out as this expert, probably until I just get more experience with it and get more training in it. My training's been a little bit more geared toward women, although the course I took with Dr. Joe and Gerard was men's pelvic, but I have less experience there. But the fascia and the anatomy, it's very similar. Our anatomy is different, obviously, but the applications with the fascia, actually, that Dr. Stecco was showing in the webinars and some of those slides, that was male models. So I actually do the same thing for the males. I just don't see as many in my practice. I've got a male physical therapist here who does FM, and some of the men may be more inclined to go to him. We don't directly market that because I want to just kind of go in the back door with it and get more experience with it first. But I think you can take the FM model and everything I'm talking about, the pelvic tilts, the education, the breathing, a lot of that has been shown to be very helpful for the men too. So I wouldn't exclude seeing a man, and I've seen men post prostatectomy, but it's just I don't have as much a population with that. So, but yeah, it's very applicable to the men as well.
How would you recommend assessing the strength of the pelvic floor muscles?
Well, I don't have much training in it, and I know there's different ways you can rate it, like with doing a Kegel and doing a digital exam, and then rating the amount of force they can generate. The examiner is basically rating it with squeezing the patient doing like a Kegel maneuver, but I don't use that because I'm generally not doing internal as much as a lot of other pelvic practitioners. So I don't have a reason to do that. I just don't. And maybe that'll be part of my future training. But since I do little to no internal, I don't have a reason to go there. I look at more with pelvic floor by function, by what they're reporting, hip mobility, and just what their complaints are. And I assess it that way. I think you can get a lot of information just by looking at the other structures around. And as a lot of the research that I shared showed, there's so much interplay between all these structures. I think if you find a dysfunction, like in the hip, you can impact whether you're perceiving someone's got a hyper or hypotonic pelvic floor, you could still impact it from an external perspective.
Can you say a few words how you work on hypermobility?
Oh, carefully and very individually. So a lot of hypermobile people, they're hurting and they have the misperception that maybe if they stretch, they'll feel better. So there's a lot of education that goes along with hypermobility. And I find a lot of these people are the ones who have a lot of pelvic issues. And I think it's not just about the pelvic segment, but they're hypermobile all over. And so you have to pay attention to what's going on in the whole body, especially with these people. Also, I think like that little girl, the last girl that I showed the example of, she was hypermobile. And I think when a hypermobile person develops a fascial densification somewhere like the knee, it has the potential to really have a big impact on them. Like it dislocated her patella. And, you know, at that age, it was already that extreme, but her hypermobility predisposed her. So a lot of education, I like to see hypermobile people be screened on a regular basis just to chat with them, check mobility, make sure nothing's changed with motion to where they're hypomobile somewhere else, and it's even exacerbating hypermobility in some other areas. And we have a brochure on that one too.
From the Canary Islands, Karina Nisa says, thank you a lot, it was excellent. But next question, from Pakistan again. This one is, how do you evaluate different fascial tightnesses, and how do you know what's normal and what's not?
Different fascial tightnesses. I'm not sure what that really means. I know what normal feels like. So I'm not really sure what the statement different fascial tightness means. I like to compare bilaterally when I'm working on somebody, and I teach that way. Especially in the trunk, we all teach to palpate both sides, even if a complaint's only on one side. So it'll give you a sense of, is it a bilateral problem? But it'll also, I find it helpful for students who are trying to learn what is normal and what's abnormal, if they can palpate the other side and feel the difference, so it can highlight differences. You're feeling for a loss of slide, density. It depends on which fascial layer you're talking about too. If it's in the hypodermis and the superficial layers, it could feel like a thickness. It might be tender just to pinch. And when somebody has that, I know I'm not on the deep fascia. I can't be reaching that tissue. So just it depends on where the depth that I'm feeling it at, and the different depths and the different problems necessitate a different approach and maybe a different tool. Like cupping, if I find superficial hypodermis to be a problem, I'll use cupping. That's a go-to for me. But I might do needling there too. Just depends. So that's how I assess it. I hope that answered that.
There's a question from Shira. Where and how have you had the most success broaching this topic and approaching the pediatric population?
Where and how have I had the most success? I believe in reaching the moms. Most of any kids I've seen come from, I treated their mom, and it's a great practice model. The women make the healthcare decisions for the family, and I get a lot of the whole family in by starting with the mom. So it's a nice opportunity to have an inroad with a family. And I love talking to the moms, especially. I talked to one the other day, got a colicky baby. So I'm trying to teach her maybe how the options with what the fascia of the baby's abdomen might be like. And maybe she can resolve it with the baby, but maybe she'll need to bring the child in for some help. Either way. But I'm happy to help the moms help their kids, and they're all over that. The moms are the way I get to the kids. I want to do I did the last brochure I did, dysmenorrhea. I distributed that to, OBGYN offices, but also to pediatric offices, because at that age, a lot of these girls, they aren't going to a gynecologist. So the pediatric office is where they see that problem too. So I got the brochure out there. When COVID's over, I'd love to go do some face-to-face visits with them, but still, I find our best marketing audience is the patient who's in our office, and the women are really receptive because they don't want their kids having problems.
It's a question from Andy. Can you discuss what you look for in regards to the treatment for vaginismus? Thank you.
The same thing. I'm pretty much going through the same treatment approach. So again, I'm not focusing on the pelvic floor. I'm focusing on, I'll look at the segment of the pelvis in the manner that I talked about, like palpating, and more of this is in that FM webinar. But looking at that segment and then something in the lower limbs, I'm going to find dysfunction, and I might address it with fascial manipulation. I might address it with needling. It might be resolved with some simple exercises that they need to work on, changing habits, breathing. all these factors that I know a lot of good pelvic therapists incorporate in practice anyway. So my first go-to is not going to be internal, and especially with a woman who has pain with penetration, I'm not going to use penetrative to try to help her. And most of them are extremely relieved. A lot of the population that I see too, they've already been through a lot of this stuff. They've already used maybe some physical therapy that was a lot of internal. They've done a lot of things their gynecologist gave them, whether it's pessaries, surgeries, medications, electric stim, internal, external. So the population I see a lot of the times are the people who haven't responded to that stuff, and that's how I get them, or they don't want to go down that route. So I tend to do exactly what I've already outlined and just look at what's going on with the lower half of the body and look at it globally, and then what do I find and address it.
Very good. You get to your last question from Naomi. Can we buy some of your brochures?
Oh, well, you can email me and we talk about it. I don't have a market for that, so, but I'd be happy to chat with you and share stuff with you. I'm a pushover for free stuff. I don't sell a lot of stuff, so just send me an email and we can chat about whatever you might have in mind, whatever one you might like.
Okay, one more question, the last bit. What sort of treatment approach do you apply normally for coccydynia in chronic stages? This is a question from Atif Hussain, also from Karachi, Pakistan.
Yeah, it's a real problem, especially like seeing somebody who's like, a fracture fall, or else from just not even a fracture, trauma or childbirth. It happens, especially if a woman's in a lithotomy position and supine, you can end up with a pretty nasty tailbone injury. It's the same. I do the same thing. So I'm looking at that lower half of the body. I'm looking at movement. What's not moving right in the lumbar segment? What's not moving right in the hips? And then I'm palpating specifically wherever. It depends on where the complaint is. I might be doing the pelvic segment for palpation, looking for where is the tissue dysfunctional. Is it the superficial hypodermis? Is it the deep? And then down in the lower limb somewhere. But then what else? What else is going on with this person? Do they sit all day long? Are they sitting in front of computers all day, watching webinars or creating webinars? So many things can play into the breathing. Are they constipated? And is that playing into part of their coccydynia? Or maybe one's driving the other. But it's really these diagnoses. All it tells me is where somebody's having some symptoms, and I'm going to look hard around that area to see what's the fascia doing in that region that might be creating that symptom for that person. But I tell you, a lot of these diagnoses I manage very similarly. To me, it's got more to do with the person and less about the diagnosis. What is this person presenting with? What's their mindset, their psyche? Is needling going to work for this one? Is exercise better for that one? So many different interventions, but basically the same thing.
Okay, what's the role of the physical therapist in the viscera?
Well, very important, I think. Absolutely. I love working with visceral problems because people come back with the musculoskeletal world. My hip's killing me, and you keep drawing out these questions. Well, what have you done in the last week? They say it's no better. It's no better. Well, I was climbing up on the roof and I was cleaning out my gutters and all. So it's a difficult read to know, did I really make a change with what I did the last time with this person? Or am I on the wrong track? Do I need to revise my approach, my treatment plan, whatever? But it's why I like knowing about their visceral problems, is because if I wrote down, and I'm very meticulous about it, that they're constipated and they have to have a laxative every day, even at that, they won't have a bowel movement except every 3 days. I write that down, and if that changed, even if they don't know what happened with their hip, they think it's worse, or maybe it's worse because of something else they did. If the viscera are easier to read, or if we went from, I was getting up 4 times at night to go to the bathroom, which can be a male or a female pelvic problem. and now I'm down to 2, then I don't really care what they're saying about their pain or their hip or anything. I know that I'm on the right track. I know that what I did the last time made a change because the viscera responded positively. And so I'm going to continue in that manner, probably on that tissue line, and work it some more, chase out some more problems in that same tissue line. Viscera, it's amazing. I wish I would have known then what I know now about it. I think we should learn about it more. And for physical therapists, I think we draw this line where we just say that's not my thing. But I think that's a mistake. And for me, the Stecco method has enabled me to be able to alleviate those lines and work on it all. And not to say that we can fix every single visceral problem. There are some things, there's, colon cancer, no, there are limits with all of us. But yeah, the viscera, I think, is way too separated from the musculoskeletal component. And that's really the point of all this. It's not even just about pelvic, but it's about viscera, whether we're talking constipation or urinary incontinence. It can have a lot to do with your knee pain.
Now we really get to the last question. This one is from Dr. Wissam Nicola in Lebanon. Have you ever considered working with needles on tight fascia?
On tight fascia. Well, I do needling. I might be needling one of those points. If I can't get something to let go, for instance, in my state, I can't use a needle unless I have a referral from a physician. But I can see a patient under direct access, which means I don't have to have a referral. I have 30 days. So I may be in a situation where I can't needle a person and I don't have the option. So my tendency is to start with the manual anyway, introduce people to their options, which includes dry needling, and get a feel for what are they comfortable with, but what are they going to need. Sure, if I can't get a point like in the vastus lateralis, with the iliotibial band crossing over it, if it's too painful to get that to release manually or even using my hypervolt, or if it just won't give it up, yeah, today I needled a lady in that very spot. So I'm not sure if that's what you mean, but I might use different needling interventions and techniques in terms of, like, I might turn the needle a little bit, or I might leave a needle in for a little bit while I work at another point with a needle. I don't think you can needle somebody without needling fascia. So I'm not really sure what's meant by have I considered needling tight fascia. Anywhere I needle, I'm influencing fascia, and it's probably dysfunctional fascia. So I think I'm impacting it.
That was the last question.
Well, very good. Well, thanks everybody. Appreciate you guys hanging in. I'm sorry it went over some, but I hope you'll consider making a donation. And thank you, Jan and Mona, for hosting this fantastic series. You guys have been fabulous throughout all this.
Very good. Thank you also, Colleen, and for everyone else, we hope to see you next week again. Same time, same place, whether it's 2 o'clock in the morning for you in Pakistan or 5 o'clock in the afternoon on the East Coast of the United States, or yesterday, that is. Next week, we're going to talk about whiplash and some of the myths around whiplash and some of the ideas that are probably important if you treat people who are in a whiplash crash, which of course all of us do. So we hope to see you next week again. Don't forget to register, and have a good evening and a good night wherever you may be in this world. Goodbye.